Thank you very much. My name is Mpapho Motsumi. I'm head of Department of Surgery at the University of Botswana. I'm here to present my work titled Comparing the Digital and the Traditional Methods of Teaching Surgical Procedure Cognitive Skill. This presentation is a prize-winning, BJS Prize-winning presentation that was done in Harare, Zimbabwe, December 2024. At our scientific conference, and I'm sharing this today as an audio recording for the audience of BJS. So the surgical procedure is the act of performing an operation, and for a trainee to learn a surgical procedure, they have to acquire technical skills, which are psychomotor and movement-oriented skills. And they also have to acquire cognitive skills. These are high-order thinking skills that entails decision-making before the surgical procedure, during the surgical procedure, and after the surgical procedure. It also entails error detection, problem-solving. As the surgical procedure is being performed, this may evolve into more complex and complicated stages, and the trainee must have that cognitive skill of making informed decisions as how to solve those problems. The other aspect of it is crisis management. This is often during the surgical procedure as well. So these skills are the subject of these presentations. The focus is not on technical skills, but it is on cognitive skills. Now, as a background, the apprenticeship model of surgical training is the gold standard worldwide. There are significant modifications to this model in other countries, but in general, this is the common model of surgical training. It has its basis in repeated observation by the trainee as the trainer does the surgical procedure, and the trainee then does the procedure, and ultimately he also teaches his own colleagues or other trainees. Hence the adage, see one, do one, teach one. Now, before a trainee attends or assists a surgical procedure, he is expected to prepare for it. And the traditional way really is for a trainee to go and read about it, study the procedure a day before or a few days before, so that when he comes to the operating room, he will have had or acquired some cognitive knowledge regarding the surgical procedure, and therefore have the demonstration aspects in theater as a reinforcement of what they already know. This approach of teaching a surgical procedure in this study is called the traditional teaching method. Emerging evidence suggests that this traditional approach or traditional method of teaching surgical procedures tends to emphasize technical skills more than cognitive skills. There is a need, therefore, for innovative teaching methods to be created to augment the teaching of cognitive skills of surgical procedures in the traditional approach of teaching surgical procedures. This study is twofold. The first part of the study created an online educational video for 4 surgical procedures. Really, that video focused in teaching cognitive skills in surgical procedures. The second part, which will be presented towards the end, really compared the digital teaching method, and the digital teaching method here refers to the educational video or the educational teaching resource. That is what this study refers to as the digital teaching method. So the digital teaching method was compared to the traditional teaching method with respect to teaching of cognitive skills in surgical procedures. Now, our focus at this point of the presentation is the creation of an online educational video, which is, of course, the digital teaching method for cognitive skills in surgical procedure. The study was a cross-sectional descriptive study, and the study designed an online educational video for teaching cognitive skills for 4 surgical procedures. The creation of an online educational video for teaching cognitive skills used 3D animation process and then to develop an educational video. The video had embedded low stakes assessments with instant feedback, and this embedded low stakes assessment with instant feedback were meant to support rather than assess learning. So participants were novice medical officers and general surgery residents at the universities of Botswana and University of Pretoria. Novice here just refers to a medical officer who has been in the Department of Surgery or a resident in the first and second year of training. Consent was obtained from participants and ethical approval was also obtained from the institutions involved in the study. The study adopted the ADI model to design the digital teaching method. And again, here the digital teaching method just refers to the online educational video. ADI stands for Analysis, Design, Development, Implementation, and Evaluation. In the analysis stage, there is a needs assessment, really focusing on who is the client, what is their need, and how to meet their need. The design is really a creation of the blueprint or an outline of how the teaching resource will be structured. Then the development stage, really the product or the teaching resource is developed. Implementation stage of the ADI model, there's quality assurance of the product and commissioning of the product. The evaluation stage really is a pilot and evaluation to see if the needs of the client, in this case, the surgical trainees, were met through the creation of the online video. Now, we'll start with the analysis stage of the ADI model. During the analysis stage, research and literature review was done, and the 10 topics outlined here were identified as components of cognitive skills of each surgical procedure. This involves introduction to a surgical procedure, indications, contraindications, preoperative preparation, demonstration of positioning, demonstration of exposure and access, demonstration of operative steps, demonstration of closure, post-operative management, complications, and their management. Trainees were asked whether these topics needed to be covered in detail or briefly, and as such, trainees were assessed through a survey. So this was the outcome of the survey. Trainees felt that certain topics should be covered in details and some in brief. So these were the topics that they felt should be covered in brief, which were introduction, demonstration of closure, contraindications, demonstration of positioning, and demonstration of exposure and access. So we see here that 22 out of the 29 who completed the survey felt that these topics should be covered in brief. However, they felt that certain topics like demonstration of operative steps in particular, complications and their management, post-operative management, pre-operative preparation, and indications for surgical procedure should be covered in details. During the design stage of the ADI model, the structure of the educational video was designed. And this was the outline of the structure. The educational video consisted of a presentation component and a 3D animation illustration of the surgical procedure. In the presentation component, there were subtopics that were covered as were assessed in the in the survey. And there was the outline, introduction, general principles, and after these topics, a pop-up of a quiz would appear. And this quiz, like I said, is meant to reinforce knowledge that was gained during the teaching of the subtopics. So the quiz would pop up, give a scenario, and ask content that was covered during the preceding subtopics. And at the end of that quiz, of course, the video would continue covering indication, pre-operative preparation, and then, of course, at the end of that, another embedded quiz would pop up and give scenarios to cover topics or subjects around the preceding subtopics. And this continued even in the 3D animation component, where the steps of the surgical procedure were demonstrated, starting with positioning, landmarks, incision sites, access. After these subtopics, a pop-up sub-quiz would appear. The trainee would answer the questions, get instant feedback, and proceed to the subsequent steps of surgical procedure, summary of surgical procedure, complications, and post-operative care. And then completing that with another quiz. And it's very important to understand that these quizzes were not really meant to assess the knowledge, but rather to reinforce the knowledge that was acquired in the preceding topics. And by so doing, as the trainee answers the question, he would get an instant feedback with a response to that. The next slide shows how would talk on how the content was designed. So during the development stage, the educational video was created using 3D animation, and we created educational videos for 4 surgical procedures. These were open appendicectomy, mastectomy and axillary clearance, below knee amputation, and inguinal hernia repair. After these videos were created using the 3D animation production pipeline. As for the quiz that was embedded in this educational video, the quiz events were created and embedded into the educational video, and each quiz question was designed to cover the first 5 levels of the Bloom's taxonomy. There are 6 levels, but we covered only 5 because the 6th level of the cognitive domains in the Bloom's taxonomy is more advanced. So the questions were meant to cover the broad spectrum of the cognitive domain. And we used the Bloom's taxonomy to assure that. The questions were mapped to the Bloom's taxonomy, and they assessed recall and remembering, understanding of a surgical procedure, application, analysis, and the abilities of evaluation of any problem regarding that surgical procedure. Now, we used an application called Camtasia, which has a quiz tool and has the ability of embedding quizzes within a video. Now, this is a snapshot of the Camtasia application with the video here in the center. And at the bottom here, you see the timeline of the video. And here on the side, here on the right side, is the quiz tool. And this quiz tool, you have the ability to set multiple choice questions, fill in the blank questions, short answer questions, and true or false questions. And depending on your response, if your response is correct, of course, you get a congratulations feedback, and then you continue. If it's correct, you are either sent to a URL with a brief explanation of what the answer should be, or you are sent back on the timeline of the video that you had just watched, just to reinforce that aspect of the question. So this was the software that was used to create those embedded assessments. And those assessments were interspersed along the timeline of the video. In the implementation phase of the ADI model, the interactive videos for the 4 surgical procedures were quality checked by an educationist and uploaded in a learning management system. In this case, we used the Moodle platform, which is used by the University of Botswana. The functionality of the interface was tested and approved. And in the evaluation part of the ADDI model of designing the digital teaching method, a self-reported survey was done on 25 residents and medical officers. All of them strongly agreed that a flexible and engaging method is needed to prepare trainees before they could observe a surgical procedure or participate in the operation of that surgical procedure. Now, the trainees or the participants who took the self-reported survey also reported increased confidence and competence after watching these videos intraoperatively. The engagement, they reported that they felt more competent and more confident to answer the questions regarding the surgical procedure. And they attributed that to the visual and interactive elements of the video that they watched before taking part in the surgical procedure. All of them strongly agreed that they were satisfied with the videos. 24 out of 25 strongly agreed that they would recommend the adoption of this. And of course, 1 out of 25 just agreed, not strongly agreed, just agreed on a Likert scale that they would recommend the adoption of this teaching method. Now, this completes the design of the teaching tool or the digital teaching method. And this digital method was designed using 3D animation with embedded assessment with instant feedback, packaged as an educational video availed to trainees online on the Moodle platform. This second part of the study compared the digital teaching method that was just reported on, was compared to the traditional teaching method with regards to cognitive skills, with regards to the ability or efficiency in teaching cognitive skills in surgical procedure. So the method here of comparing the two, which is the traditional and the digital method, was a quantitative experimental study design. We used a crossover repeated measure study design to determine the difference in knowledge gain, knowledge retention, using pre, post, and retention tests. Participants at the end also did a satisfaction level assessment using a survey on a Likert scale of 1 to 5. The hypothesis in this part of the study was that novice surgical trainees who were taught cognitive skills in surgical procedures using the digital method would perform better than those taught using the traditional teaching method in terms of knowledge gain, knowledge retention, and self-reported satisfaction level. Now, for clarity, in the teaching interventions that are being compared here are one, the digital teaching method, which is the educational video, and the traditional teaching method that was explained in the first part of the presentation. Now, this is how the two were compared. So in the traditional teaching arm, trainees or participants were given an outline to go and prepare for the a specific surgical procedure, the same way they would have done if they were to go and assist the same surgical procedure in theater. Most often in our survey, we discovered that most of the trainees actually read as a way of preparing for a surgical procedure. So this would be the traditional way of preparing. And they were given a day to prepare. And in the digital arm, the participants were given an educational video, which lasted a maximum of 15 minutes with the content covering the cognitive skills of the surgical procedure with the same outline. So the video also covered introduction, principles, indications, contraindication, pre-ops, stages of the surgical procedure and complication. So they were covering the same content, either traditionally or using the video. Now, this was the design of the study. At the beginning, when the trainees enrolled, they were given a chance to draw from a cup containing the 4 surgical procedure names. The first draw would be named Procedure A, and the second draw would be named Procedure B. I will explain as we go why each participant needed to have Procedure A and Procedure B. The second stage was that each participant, or the participants, were divided into 2 groups, Group A and Group B. And this depended on their enrollment order. So those whose enrollment position was an odd number would go to position A. Those whose enrollment position is an even number would go to Group B. Now, this division into 2 groups ensured that the first teaching method, that half of the participants will start with the traditional teaching method, while the other half will start with the digital teaching method, to remove the order bias in testing the efficacy of the 2. So during the third stage, or period 1 of the study, Group A started with the traditional teaching method, and during that time, they would first start by taking a pre-test before the teaching. So they would do a pre-test, all of them, before the teaching intervention was implemented. And then Group A would be taught using the traditional teaching method regarding Procedure A. Remember, they each have 2 procedures. And then Group B would start with the digital teaching method and teaching Procedure A. So once they completed, so this will be after a day, and this one was 15 minutes. And once they are happy watching the video, they'll be asked if they are ready to do the post-test for the digital teaching method. If they are once they are ready, they will do a post-test. The difference of the mark between the pre and the post-test would be called improvement mark, or the difference score. And this is a marker or a measure of knowledge gained. In the second period of the study, the half, or Group A, Group B, who started with the digital teaching method, would now move on to the traditional teaching arm. And those who used the traditional teaching arm in period 1 would then move on to the digital teaching. However, the teaching method then focuses in teaching Procedure B during period 2. And this is to avoid the carryover effect, because if you learned the same procedure in period 1 and you are tested in the same procedure in period 2, you would have had some knowledge that you gained during period 1. Hence, the creation or the need to draw and have 2 procedures for each participant. So then here, of course, during period 2, they also did pre-test at the beginning, and then they would have an intervention. The traditional ones would go and read for a day, come back the following day and complete the post-test. The digital teaching arm would complete the post-test once they are satisfied with watching the video. Now, the difference between the pre and the post-test, of course, here is also taken as the improvement mark or the difference score. And this is a measure of the knowledge gained. After each participant has experienced both the digital and the traditional teaching method, a survey was then taken to assess the satisfaction level on a Likert scale of 1 to 5. This was done using a survey or a questionnaire. We also assessed the clarity of each teaching intervention, how trainees felt that each teaching intervention was clear, or the level of clarity from each teaching intervention. 2 weeks later, a retention test was performed. And this was really for each participant being assessed on all the procedures that they were taught. And of course, the same thing was done to calculate the improvement score. This was to assess how much knowledge they retained after 2 weeks. Now, these are our results. 31 participants were enrolled and 21 completed the study. The male to female ratio was about 1 to 2. The mean age was 31.5 with a standard deviation of 3.7. Average time that each participant spent in the surgical department was almost 2 years. The difference in knowledge gain and knowledge retention was assessed. And this was a plot of the improvement marks, the ones that I've also called the differenced scores. So the dotted line here is the traditional teaching method. So when we plotted the distribution of the different scores or the improvement marks for the traditional teaching method, this was the distribution we got. For the digital teaching method, we see a right shift. This right shift signifies an improvement in the marks, therefore signifying that there was an improvement in or a greater improvement in the digital teaching group. We further assessed the significance of this observed difference using the paired sample t-test. And the outcome of that assessment of the significance is that the mean difference score for the digital teaching method, which was 3.59, was significantly greater than that of the traditional teaching method, which was 1.93, with a p-value that was less than 0.001. We did the same with the assessment of the knowledge retention. Remember, this was knowledge retention assessed after 2 weeks. Same thing, the dotted line here is the improvement mark or the difference scores for the traditional teaching group. And the solid line here is the improvement marks for the digital teaching intervention. And we see also here a right shift, also signifying a greater improvement in the digital teaching method. And we did a paired sample t-test to also assess the significance of this observed difference. And we found that the mean difference score for retention score for the digital teaching method was significantly higher than that of the traditional teaching method, with a p-value less than 0.001. The satisfaction level and teaching method clarity was also assessed using a survey on a Likert scale, and all participants indicated that the digital teaching method was better in teaching cognitive skills compared to the traditional teaching method. 24 out of 25, remember we had 29 participants, but we had a fallout of 4 who didn't complete the survey on recommendation. That's why we have 24 out of 25. So the 24 out of 25 strongly recommended the adoption of the digital teaching method to augment the traditional method. Of course, we are not saying we want to phase out the traditional teaching. It's just to say we need a method to augment the traditional teaching method and ensure that the cognitive skills of surgical procedures are well covered in a more systematic and procedural way. And 1 out of 25 just recommended, not strongly recommended, recommended the adoption of the digital teaching method. In conclusion, in this study, we designed lecture-created videos for teaching cognitive skills in surgical procedures using 3D animation videos with embedded low-stakes assessment and instant feedback. We followed or used the ADDIE instructional design model. We used the ADDIE instructional design model And this designed teaching resource was called the digital teaching method for cognitive skills of a surgical procedure. The digital teaching method yielded better knowledge gain and knowledge retention than the traditional teaching method in teaching cognitive skills. Participants were more satisfied with the digital teaching method, and we recommend the adoption of new innovative, systematic, and sequential methods, such as the one we designed to teach or augment the traditional teaching method in teaching cognitive skills of a surgical procedure. We do acknowledge that further studies are required, but this is an area that needs to be studied. The assumption in this study is that when a surgeon is well-grounded in cognitive skills, there is a likelihood or a good chance that their surgical outcomes will be good. Thank you.